Welcome to medAIc Reviews.
It seems pretty simple on the surface, right? A series of pokes and prods, but it is so much more than that. It's actually a really elegant sequence, and every single step is designed to uncover vital clues about what's happening inside the body. In this explainer, we're going to break that whole sequence down, but we're going to focus not just on what doctors do, but the crucial why behind every single move.
So here's the game plan. First, we'll talk about setting the stage. This is all about patient safety and comfort. Then we'll get into the critical, and I mean critical sequence of looking and then listening. After that, we dive into the hands-on stuff, tapping and touching. We'll see how those are used to check out specific organs. And finally, we'll look at how special tests help pull all the clues together.
All right, let's start at the very beginning, because you can't build a house without a foundation. This first phase is all about creating an environment of safety and comfort. And as we're about to see, getting this part right is just as important for the diagnosis as the exam itself.
Now, you might think this is just about having a good bedside manner, being nice. But it's way more than that. As Dr. Tassi Guildford points out, it's clinically essential. Think about it. If you're nervous or uncomfortable, what do? You tense up. You clench your stomach muscles. Well, if those muscles are hard as a rock, there is no way a clinician can feel the organs underneath. So a relaxed patient literally means a more accurate exam.
So, how do we make that happen? Well, it's a few simple but crucial steps. You start by having the patient lie flat on their back. A pillow under the head is great for comfort. But here's a pro tip. A pillow under the knees does wonders to relax the abdominal wall. And of course, you drape them appropriately, so only the abdomen is exposed. It's all about making sure the patient feels secure and dignified.
Okay, our patient is comfortable. The stage is set. Now the real investigation can begin. And what's so interesting is that the first two formal steps of the exam, they don't involve any touching at all.
That's right. The first thing a clinician does is just look. It's pure observation. They're taking it all in, like a detective at a crime scene. They're looking at the patient's face for any hint of pain, and they're looking at the abdomen itself. Is it flat? Is it rounded? Is it symmetrical? Any scars or weird pulsations? These are the very first clues.
So you've looked. The logical next step seems obvious, doesn't it? You'd think it's time to start feeling the abdomen to see what's going on.
But nope, that's wrong. And this is probably one of the most important takeaways. We listen before we touch. This is called auscultation. And the reason is so simple but so critical. If you start poking and prodding the belly, you're going to stir things up and create bowel sounds that weren't there before. To get a true, unbiased listen of what's happening in there, you have to do it first. The rule is always look, then listen.
So what are they listening for with that stethoscope? Two main things. First, just normal gurgling bowel sounds in all four quadrants. Are they there? Are they super active, or are they completely silent? That tells a story. Second, they listen over the big arteries for something called a bruit. It's a whooshing sound. Think of it like a kink in a hose. It can be a sign that an artery is getting narrow.
So we've looked, we've listened. Now it's finally time to get hands-on. We're moving into percussion, which is just a fancy word for tapping, and palpation, which is touching.
Percussion is such a cool, old-school technique. It's kind of like tapping on a wall to find a stud. By tapping on the belly, you can figure out what's underneath based on the sound. If you hear a hollow, drum-like sound, that's called tympany, and it means there's air. But if you hear a dull thud, you've found something solid, like the liver or another organ. It's like using sound to map out the body's internal geography.
All right, now for palpation, or feeling the abdomen. And this brings us to the single most important rule for patient safety. If a patient tells you, "Doc, it really hurts right here," you examine that spot dead last. Every single time. Because what happens if the first thing you do is poke the part that hurts? The patient will immediately tense up, guarding that spot, which makes the rest of your exam totally useless. And you've just caused them unnecessary pain. Save the sore spot for last.
And the touching itself is a two-pass process. You start with a very light touch, going through all the quadrants just to check for any tenderness right on the surface. Then you go back and do a deeper palpation, maybe using two hands to feel the organs that are further down. And through this whole thing, the clinician's eyes should be on the patient's face, not their hands. You're watching for even the tiniest wince of discomfort.
Okay, so we've got our techniques down, tapping and touching. Now let's see how we can use those tools to get a really good sense of what's going on with some of the big-ticket organs in there.
Let's start with the liver. By using percussion, that tapping method, you can actually figure out how big it is.
You tap down from the chest until the sound changes from hollow to a dull thud. That's the top edge. Then you tap up from the belly until you hear that thud again. That's the bottom edge. Measure that distance, and it should be between 6 and 12 centimeters in a healthy adult.
Next, you actually want to feel the edge of the liver. The clinician will press in under the right rib cage and ask the patient to take a big, deep breath. That breath pushes the liver down, hopefully right into their waiting fingers. A healthy liver should feel smooth, and it shouldn't be tender. If it feels hard or lumpy, that can be a sign of something like cirrhosis.
This next one is pretty amazing. You can actually estimate the width of the aorta, the biggest artery in your body, just by feel. By pressing deep in the upper abdomen, you can feel its pulse on either side of your fingers. You're trying to get a sense of that width, and it should be less than 3 centimeters. If it feels wider, that's a major concern for an aortic aneurysm, so this is a really important screening tool.
Okay, we've done the fundamentals. But what if the exam so far, where the patient's story, points towards a specific problem? Well, that's when you bring out the special tests to help zero in on a diagnosis. For instance, what if someone's belly is really swollen? Is it just gas, or could it be fluid? That fluid buildup is called ascites, and there are 2 really neat tricks to check for it. One is the fluid wave, where you tap one side of the belly and literally feel for a wave hitting your hand on the other side. The other is called shifting dullness, where that dull, thudding sound from percussion actually moves when the patient rolls over because the fluid shifts with gravity.
And what about a problem with the gallbladder? There's a classic test called Murphy's sign. The clinician presses down where the gallbladder lives and asks the patient to take a deep breath. If the gallbladder is inflamed, it gets pushed down into their fingers, and the patient will feel a sharp pain and suddenly stop breathing in. That sudden stop is what they call a positive Murphy's sign.
Of course, there's the big one, appendicitis. There's a whole toolkit just for this. You've got tenderness at McBurney's point, that's the classic, but then you have these other signs, the Psoas sign, the Obturator sign. The basic idea behind these is to have the patient move their leg in specific ways. This stretches nearby muscles, and if the appendix is inflamed and angry, that little bit of jostling will cause pain, helping to confirm the diagnosis.
And we're not quite done yet, because the exam actually goes around to the back. A clinician gives a gentle but firm thump over each kidney. This is to check for CVA tenderness. Now, if your kidneys are fine, you'll barely feel it. But if you have a nasty kidney infection, that simple tap will be surprisingly painful. It's a huge red flag.
So when you look at the whole picture, it's clear the abdominal exam is this beautiful, systematic investigation. It's not just a random collection of maneuvers. It's a logical story where every step, from ensuring comfort to looking, listening, tapping, and touching, builds on the last to safely gather as many clues as possible. Because in the end, that's what it's all about. Each of these findings, a specific sound, a feeling of tenderness, the texture of an organ, is just one small clue. On its own, it might not mean much. The real art of medicine is taking all of those little clues and weaving them together to tell a coherent story, a story that explains what's happening and, most importantly, points the way toward getting better.